أعزائي الطلبة، اليوم موضوعنا infections affecting the nervous system. First of all, you have to understand how does a microorganism can reach, or how does a microorganism reach the central nervous system. This occurs either through a hematogenous route or through direct implantation, or due to local extension secondary to an established infection in a nearby site, or through peripheral nervous system. Hematogenous spread is the most common means of entry, and infectious agents ordinarily enter through the arterial circulation. However, retrograde venous spread can occur through anatomic connections between veins of the face and cerebral circulation. This diagram can show how an infection in what is called the danger area of the face can reach the central nervous system by way of valveless veins, connecting the veins in the face to veins inside the cranium. Also, direct implantation, this may occur due to trauma, or can be iatrogenic, or can be due to the presence of certain types of congenital malformations, for example, meningomyelocele. Local extension occurs secondary to an established infection in an air sinus, most often the mastoid or frontal, or an infected tooth, or a surgical site in the cranium or the spine. The spread of infection through peripheral nervous system usually occur with certain types of viruses, for example, rabies and herpes zoster. The damage to the nervous system, which is due to infection, is either due to direct injury of neurons or glial cells by the infectious agent itself, or by an indirect way. Indirect way, this include elaboration of certain types of toxins, the destructive effects of inflammatory response, or immune-mediated mechanisms. Now we come to the one of the most important subjects in daily clinical practice, which is acute meningitis. Meningitis is an inflammatory process of the leptomeninges and CSF within the subarachnoid space. Meningoencephalitis is the inflammation of meninges and the underlying brain parenchyma. Meningitis is usually caused by an infection. There is what is called chemical meningitis, and this occurs in response to non-bacterial irritant introduced into the subarachnoid space. Infiltration of the subarachnoid space by carcinoma is referred to as meningeal carcinomatosis, sometimes called carcinomatous meningitis, and that which occurs by lymphoma is called meningeal lymphomatosis. The classification of infectious meningitis on the basis of characteristic of inflammatory exudate on CSF examination and the clinical evolution of the illness, we can classify infectious meningitis into acute pyogenic, usually bacterial meningitis, aseptic meningitis, usually acute viral meningitis, and the chronic, which is usually tuberculous, spirochetal, or cryptococcal. Regarding acute bacterial pyogenic meningitis, the cause is variable with age. In neonates, the most common agents encountered are Escherichia coli and group B streptococci. In elderly, Streptococcus pneumoniae and Listeria monocytogenes. In adolescents and in young adults, the Neisseria meningitis. Clinical features: the systemic signs of infection superimposed on clinical evidence of meningeal irritation and neurological impairment. Headache, photophobia, irritability, clouding of consciousness, and neck stiffness. A CSF sample, or what is called the spinal tap, yields cloudy or frankly purulent CSF under increased pressure with as many as 90,000 neutrophils per cubic millimeter, a raised protein level, markedly reduced glucose content, and bacteria may be seen on a smear or can be cultured. We have what's called Waterhouse Frederickson syndrome, which is common with meningococcal and pneumococcal meningitis. It is caused by meningitis-associated septicemia, hemorrhagic infarction of the adrenal gland, and the cutaneous petechiae are the main features. Now we come to acute aseptic or viral meningitis. It is a clinical term referring to the absence of recognizable organisms in an illness with meningeal irritation, fever, and alteration of consciousness of relatively acute onset. The disease is generally of viral in origin, enterovirus, and rarely of bacterial or other etiology. The clinical course is less fulminant than that of pyogenic meningitis. The CSF shows typically an lymphocytic pleocytosis. The protein elevation is only moderate. The sugar content is nearly always normal. The viral aseptic meningitis are usually self-limiting and are treated symptomatically. Drug-induced aseptic meningitis, a form of aseptic meningitis associated with some classes of medications, including non-steroidal anti-inflammatory drugs and antibiotics. A form of aseptic meningitis may follow rupture of an epidermoid cyst into the subarachnoid cyst or space, the introduction of a chemical irritant, chemical meningitis. The CSF is usually sterile, pleocytosis with the neutrophils, a raised protein level, and sugar content is usually normal. Now we come to the subject of a brain abscess. This occurs due to direct implantation of organisms or from local extension from adjacent foci, for example, mastoiditis and paranasal sinusitis. Hematogenous spread usually from a primary site in the heart, lung, or distal bones, or after tooth extraction. And there are certain predisposing conditions, for example, acute bacterial endocarditis, which tends to produce multiple abscesses, cyanotic congenital heart diseases, in which there is a right to left shunt and loss of pulmonary filtration of organisms, and chronic pulmonary sepsis, as can be seen with bronchiectasis. Streptococci and staphylococci are the most common offending organisms identified in non-immune suppressed populations. Clinical features are those of progressive focal deficits in addition to the general signs of raised intracranial pressure. CSF is usually under increased pressure, the white cell count is raised, protein levels are raised, and the sugar content is normal. The increased intracranial pressure and progressive herniation can be fatal. Abscess rupture can lead to ventriculitis, meningitis, and venous sinus thrombosis. Most common brain regions that are affected in descending order of frequency are the frontal lobe, the parietal lobe, and the cerebellum. We stop here and we will continue in the next session.